Dr. Stephen Haskins, thank you so much for joining us all the way from United States. How are you doing?
I'm well. Dr. Pawa, it's nice to see you.
Absolutely. Listen,
It's
Steve, you were an integral part of our RUK 19 meeting in Belfast, where we got to see you in person. You got to take the stage. Unfortunately, plans are slightly different now. They've been affected, of course, by the COVID-19 pandemic, but we are thrilled that you are still agreeing to be part of this meeting. Tell me what you're looking forward to about RUK 21.
I think it's what's exciting for me is this is the first time that I get to discuss our ASRA, it's the American Society of Regional Anesthesia and Pain Medicine, point of care education, recommendations for education and training. And so this was something that was published in Regional Anesthesia and Pain Medicine just a few weeks ago. And so this is going to be the first meeting where I get to do a deep dive into what we recommend and why, something that we've been working on for almost 2 years now. So this is the first time. It's going to be the debut. I'm sure
Wow.
I'll talk about it many times afterwards, but very much looking forward to that, including being a part of that incredible POCUS panel. You have, some superstars that are going to be putting on quite a show, I hear.
Well, absolutely. And I think what was amazing or what was really interesting about the 2019 meeting was the first time that we really brought point of care ultrasound into this regional anesthesia meeting. And what you guys have demonstrated with this great two-part publication is that as regional anesthetists who are already using ultrasound, it's a very natural transition to start to take on these extra skills. Um, why do you think, Dr. Haskins, that people should book and join up to this virtual meeting, which of course is accessible to everyone across the world?
Well, I really enjoyed the RA UK 19 meeting, and I think what's remarkable, because I go to a lot of meetings like this, was it was equally entertaining as it was educational. I think you guys really make a lot of effort to ensure that people enjoy themselves, and they make learning a lot of fun. So I'm thinking about sort of the pro con debates and some of the introductions and I think every faculty member who's involved really takes great pride in not just being a phenomenal educator, but someone who is engaging with the audience and in many ways sort of entertaining as well.
Well, fantastic. And you're an instrumental part to that. So thank you for joining us for the meeting. You've seen some of these videos already, Dr. Haskins. You know I'm going to ask you three questions. The first of which is, what is your favorite upper limb block? Then your favorite lower limb, and then finally your favorite trunk block. Over to you.
So my favorite upper limb block, this is something that we published actually here at HSS a couple years ago, the superior trunk block. I think that's something that I have been using for every sort of shoulder surgery and anything that is basically mid-humerus on up. And I think the benefit of that is not only is it a great dense block, you get the brachial plexus, suprascapular nerve, but you avoid the phrenic nerve, which I think
Hmm.
is a very unique benefit to that over some of the more traditional blocks like an interscalene or even supraclavicular. That's what our study showed is that 90+% of the time, if performed correctly, you preserve diaphragmatic function. So for me, it's sort of a win-win, and it's nice to have a patient come out and be able to do this,
Yeah, yeah, absolutely.
but have zero pain in their shoulder.
Okay, lower limb.
So this is recently I have sort of fallen for two blocks because I think they supplement each other
Okay.
very well, which is the PANG block, so the pericapsular nerve group block, and the CFI, the suprainguinal fasciolae block. And the reason for that is I think it may actually finally be that secret sauce that helps with hip pain. Total hips have been a mystery. Lumbar plexus helps a little bit, but then, they have quad weakness afterwards. Fasciolae, same thing. So with the PANG, you get sort of that anterior capsule really nicely with the CFI, you get, for the posterior hip in particular, you get that lateral incision with the lateral femorocutaneous. And it's something that we're doing on, not only our total hips, but we're doing them on our hip scopes, hip arthroscopies, and for our periacetabular osteotomies. It's
Wow.
actually cut about a day off of a lot of our patients' hospital stays for these big pelvic reconstruction surgeries that we do here. So too, cheating a little bit, but I do think they complement each other very well.
Okay, I think I'm going to give you that because I'm very excited about that. And we've got a hip session happening at the end of day one, so hopefully they'll talk about that. And then finally, Steve, to finish up, tell me what your favorite trunk block is.
So it's interesting because here at HSS, we don't do a lot of surgery that goes along with trunk blocks, not a lot of abdominal surgery, breast surgery. Here I would say for spine surgery, what's become very popular is the ESP. We certainly use that, a great deal because it certainly helps. It doesn't cover everything, but it helps a lot. Personally, don't do a lot of spine, so I haven't done a lot of ESP blocks for that purpose, although I do find it to be sort of a very, it's a great block to perform, very straightforward for most people who are sort of regional anesthesiologists. I've done a lot of quadratus lumborum blocks, and it's a very satisfying block when you see that spread, and particularly with the transmuscular, the separation between the psoas and the QL. But I'll say ESP.
Okay, cool. This is Dr. Haskins. Thank you so much for joining us. I really look forward to seeing you and your contribution on that inaugural discussion of your two-part POCUS paper in May this year. Take care, and I'll see you soon.
All right,
Bye-bye.
thank you so much.